A very good morning, everyone. Welcome to SIMCON 2023, the 7th annual academic sessions of Sri Lanka College of Internal Medicine. On behalf of the organizing committee, I would like to thank you all for coming today. We are delighted to have such a large turnout of internal medicine physicians, trainees, and other healthcare professionals. Today's program is packed with exciting and informative sessions covering a wide range of topics in internal medicine. We have invited some of the leading experts in the field to share their knowledge and insights with us. To start the first segment of today's program, I would like to invite Dr. Tujara Matthias to introduce the speaker to the audience. Over to you, ma'am.
To start off the first session of SIMCON 2023, we have a very important session for practicing physicians and trainees. And to start off the lecture on clinical trial and laboratory investigations, a critical appraisal, I warmly welcome Prof Sarath Lekamwasam, MBBS, MD, FRCP, PhD, and FCCP, the Chair Professor of Medicine of the Department of Medicine, University of Ruhuna. Over to you, sir.
Good morning. Good morning, everybody. Thank you, Tushar. I wanted to start my lecture referring to cricket and saying that I'm the opening batsman, but then after seeing the performance of the Sri Lankan cricket for the last couple of weeks, I changed my mind. So first of all, I congratulate all of you who have come early in the morning to listen to me. You are very brave, really. So the topic given to me today is that the critical appraisal of clinical trials and lab investigations, and then I thought I would squeeze a little bit of your meta-analysis as well. Because these are the bread and butter of a physician in general, and it is very important that the college recognize this aspect of the medicine as an important area for the clinicians. Because probably, sorry, I'm just having a little upper respiratory infection. The college recognizes probably that the clinician need to be a lifelong learner, because lifelong learning is a continuous process which sort of keep the clinician up to date, and then he becomes a good doctor. There are various methods or various ways to be a lifelong learner, and one thing would be learn in the workplace, which has its limitations on its own. And there are inputs you can get from the others and also get feedback, and then you can improve your practice. Again, it's not a bad thing, but again, there are limitations. But what is widely practiced is what is called the use the evidence at the point of care. So that clinician will be updated. But then having said that, there was a dilemma of the clinician is that there are fake research and publications around. There are plenty of those. And also, the publication which are not really a fake, and people have done research, but again, there are what are called flaws in the research methodology, and also research methodology and analysis, there are plenty of flaws, and so that the results do not become credible. I'm not going to have a lengthy discussion on what's called research misconduct, and here what we mainly focus on what is called the falsification. The falsification is that the manipulation of research materials, equipment, or the processes, or change or omitting the results such that the results is not accurate, reflecting what it should be really. So that's a falsification is the area that we are mainly looking in this particular lecture. Now, is it a sizable problem? This actual retraction rate of articles in reproductive medicine, the electronic search of these people, the authors, when they search electronic databases, they found nearly 520,000 publications in the field of infertility and the fertility care. But they found that nearly about 2,400 articles have been subsequently retracted. And that's about 41% of them were randomized clinical trials. But only there's another article, actually, I didn't want to include a lot of the information article, that how many of these publications which have been retracted have got into what is called guidelines, because people who are doing guidelines, again, are quite, are not aware that these articles have been retracted. Because the retraction comes as a very small 1 or 2 sentences in the subsequent journal subsequent publication, saying that such and such an article in the previous issue have been retracted. Doesn't give very much of prominence really, and then as a result, sort of, people do not know these articles have been subsequently retracted for various reasons. And also that's something we had to be aware of, what is called the discrepancy between the really people have, whether they have done the research or what they have done and what they are reporting. Now, there can be a discrepancy between the two. And maybe that people have done it, but they are not reporting it actually. Or maybe they are reporting, but they have really not done it really. Let's say randomization, they might describe the very robust description of randomization, but really they haven't done it actually. Or maybe they have done it actually, but they are not reporting. So the consort guidelines, people should be aware of, clinicians should be aware of what's called consort guidelines, were first developed as to give clinicians who are doing, researchers who are doing clinical trials, to give a little platform, a checklist for publications. But now that is increasingly used when they are developing their proposals. So people refer to consort guidelines not to miss out anything. Now, can we have a little quality assurance of these publications? There are numerous methods of doing that. What we are using mainly what is called Juddard score. The Juddard score is a fairly ancient concept where marks are given for randomization, blinding, and withdrawals, and then based on that, the articles can be scored, and then based on their quality. I know that you all are aware of what is called evidence pyramid. I'm not going to go to the details. At the apex, you got what are called systematic reviews, meta-analysis, and randomized clinical trials. But I'm going to actually focus on what I call why this pyramid has been made in such a way, because the biases and confounders become weaker and weaker, become lesser and lesser as you go up on the ladder. So here at the base, the research methods at the base, they are abundant with what are called the biases and confounders. So that's actually as you go up and up, the biases and confounders become a rarity. What is bias and confounders? Bias is a systematic error which is committed from the plan into the publishing. There can be what's called publication bias, and also can be a systematic error. It's not a random error, it's a systematic error. The confounder is a third variable connected with exposure and the outcome. For example, you can connect between the exposure and outcome. Let's say a coffee consumption is connected with acute myocardial infarctions, but then somebody might argue and say, well, it's not a coffee consumption, it's actually smoking, because smoking is connected with coffee. Smoking is connected with acute myocardial infarction. So it's not really coffee, it's actually smoking, work through smoking. So smoking is a confounder. So that's what's called confounder, third variable. So the basically critical appraisal skills depend on what I call identifying the various biases and confounders which can occur which can be detected in the research methodology. Also, that we know that the critical appraisal is an important component of what is called the evidence-based medicine. Evidence-based medicine, basically what is called the acquisition, appraisal, and application. Three things. The acquisition is you acquire the information and then appraise and then apply on your patients. Now, I'm not going to go to the details of that one because that's we should just run it, so it is a very popular topic. I have taken only a couple of areas, what is called recruitment process, allocation of patients, the maintenance and what's called follow-up period, measurements, and the study statistics. Those are the ones I'm going to concentrate mainly in critical appraisal. One thing is to find out who were the patients, and how were they recruited. And this is actually in what is called the case definition and also recruitment criteria. So in the article, what's called the cases. What is a case? And one of the major development in medicine is what is called the defining a case, what's called caseness. And then a group of what are called signs and symptoms and put together and you define a case. That has been a major achievement in medicine. Now, case definition, we define case should not be too broad, and then it becomes vague and it becomes sensitive, and then many unnecessary cases can creep into that population. And also should not be overly restrictive, and as a result, some patients with the disease also get eliminated in the process in the case definition. So definition should be acceptable to clinicians used in the clinical trial. The representativeness of cases, ideally cases should be a random sample of all possible cases of interest in the source population. Let's say you take patients with diabetes in the clinic, and the patients should be a random sample of patients from that representative sample. But again, we commonly include what are called available cases, patients who come to hospital, clinics, and they normally be representative. So there can be certain problem with that case selection. Now this particular study looked at what is called the dementia. They found that the exclusion criteria of a patient with dementia, but also who had a cardiovascular disease, comorbid delirium, intellectual disability, and had a schizophrenoid symptoms. So those patients were excluded. But then someone analyzed those patients, the patients with dementia with a cardiovascular disease or a comorbid delirium or intellectual disability, and those people having higher mortality compared to patients who do not have those. So really speaking, you are eliminating group of patients who are having high mortality and morbidity, and then they are not actually represented in these what are called studies on dementia. So authors concluded that overly stringent randomized clinical trial exclusion criteria and may compromise, and then they do not allow what is called the heterogeneity of the vulnerable population to be represented in the study population. So that's one of the things that we have to be careful about. Now, eligibility criteria in general. The eligibility criteria that should be explicitly described in the methodology, and also criteria used should be very clearly stated. So you capture the patients with the disease, and you exclude the patients who may be harmed, like pregnancy, lactation, high-risk people. Inclusion criteria. Now, a clinical trialist try to include what are called patient with a high-risk patient with that particular condition, because they want during that follow-up period as many as possible to develop what is called clinical outcome. For example, let's say if you are doing a clinical trial on lipids, there's no point of taking a 20 to 30-year-old people with the lipids and then run them for 2-year clinical trial, because very few of them develop myocardial infarction during that period, because they do not have a high risk of getting acute myocardial infarction at the baseline. So they would take a patient who's got a diabetes, hyperlipidemia, who has already got, let's say, ischemic heart disease, and then into the clinical trial, so that the possibility of them developing acute myocardial infarction during the trial period is high. So they take high-risk patients. So this compromises what's called generalizability of the results, because they do not include the whole spectrum of disease and the patient characteristics. Now, exclusion criteria need to be a valid reason for exclusion. It's an unacceptable risk to place them on a placebo, and then that patient should not be excluded. There are vulnerable groups, as I said, treatment unlikely to be effective, and other practical reasons you exclude. Now, for an example, randomized clinical trials in osteoporosis mostly include postmenopausal women with osteoporosis. That's defined by the T-score, lesser than -2.5. And then that is not enough. They generally need to have at least one fragility fracture, and sometimes 2 fragility fractures. But then a postmenopausal woman with just osteoporosis only, without a fracture, does not get included in the study sample. But then it is not stated in the exclusion criteria. But where it is defined, the inclusion criteria, you can clearly see that the patient just with osteoporosis, but without a fracture, get eliminated. But then we treat that patient with osteoporosis without a fracture with the same medication. But then do not realize that actually that patient had no chance to be in the clinical trial. Now, these people looking at what are called the representativeness of patients who are in the clinical trial, they found nearly about 90% of patients of that disease were not represented in the clinical trial. So that shows what's called magnitude of the particular problem. that the patients who are not in the clinical trials are not really representative of what are called the really patient population. Now, random allocation. When you ask question why you have to do randomly select people, usual answer is what is called it avoid what is called selection bias. So that's true enough. Is avoid selection bias. It doesn't allow patient or the clinician to just send the patient wherever they like. But then what is more important is that the randomization ensures that there are two prognostically similar groups when the groups are randomized into two. And then you can find these two groups of people at the baseline are prognostically equal. So if there's a difference in their clinical outcome, and that is attributed to the treatment given during that study period. So that's a basis and that's a principle that we generally work with when you're doing clinical trial. So if we say that if the randomization is done properly, with adequate numbers of course, and then it ensures that all characteristics, what are called the people characteristics, which are measurable, unmeasurable, known, unknown, and then they all get distributed equally between the two groups. So that the randomization ensures that. So the major confounders get equal distributed. Now, for example, let's say smoking, and if smoking gets the habits get equal distributed between the two groups. But again, what about the pharmacodynamics and the pharmacokinetics? So which are really not measurable, but we know these are important. We know there are important concepts in the drug handling. So the randomization ensures that even those things get randomly get equal distributed between the two groups. And that is why what's called table 1 given in the randomized clinical trial publications generally displays compare the two groups in this particular table. And then I think Lancet, New England Journal of Medicine, a long time ago got rid of what is called the column for the p-values. Now earlier we used to have a column. These are what I call the patients and maybe a treatment group and a placebo group. Earlier they used to have what is called the p-value here, and mostly non-significant because they are not, if randomization has been done, and then generally this column has to be a non-significant between the two groups. So got rid of that. And if there's a significant difference between the two groups with regard to a certain measurement, and that has to be because of it's a random, it's a random occurrence, and then usually you state at the bottom saying that these variables were not significantly different, and that is by chance actually, it is due to chance. There are different methods of randomization: simple randomization, stratified, block randomization, and there are various ways that people use. But then it is how they are reported. This particular study on EMPA and PIO on the left ventricular function, published recently, they said the computerized block randomization method was used for randomization. Participants were randomized to receive either this drug or that drug. So they give a little description how it was done. So you have to say this is generally what we are using at the moment is what is called the computer-generated random tables, not the old books, at the statistic books, tables at the back you got the random table, but they all gone now. They are what is called the randomization by a computerized method. Allocation concealment is people do know what type of treatment has been given. So there are sealed, opaque envelope, third-party objective given through objective computer. Let's say that a clinician recruiting a patient was required to contact the central unit to obtain the patient treatment assignment. So there's a description given. That envelopes contain the allocation consequence were sealed and numbered. So like that, we had to give a little description how that is done. There's a blind-in, what people call it masking sometimes, not the same as allocation concealment, it's a different concept. Attempt to make the treatment being compared indistinguishable to all the stakeholders. Now patients, when they know that they are on a placebo, and then they have a lot of complaints. They know that they are on a placebo. And then the treatment group, they have a lot of side effects. So people, when they get to know about whether they are on a placebo or treatment, then they will have various complaints related to that. The clinicians, when they get to know that when they're unblinded, then they take more care of the patients who are on a placebo. Maybe give a little herbal preparation, or can ask them to do more exercises. And also investigators, they may ignore side effects. And outcome measures may violate the criteria to define outcome. So patient nephrotic syndrome, if you are looking for, let's say, relapse, and when the proteinuria comes, and if the assessor wants, to prove it is not a relapse and might do a urine culture, urine full report and everything. But if you want to support that is a relapse, then of course he might not do any of those and try to exclude UTI. So blinding, you have what is called typical single-blinded, double-blinded, and then now we need to specify who and who are blinded. That's not good enough. So we specify the groups that are blinded: patients, parents, when to pediatrics, clinicians, investigators, outcome assessors, and even statisticians should be blinded. So once the data is shown or finally analyzed, only the blinding should be broken, and then say group 1 received this and group 2 received this. And this is what what is general recommended. Current literature has identified what groups should be blinded. They say laboratory technicians, outcome assessors. So there are groups of people who should be blinded. So not only just say single blinded, double blinded. The follow-up should be adequate to observe clinical outcomes. Too short, less clinical outcomes, and then there's no enough statistical power in the study. Too long, there's a high dropout. And also make sure similar care has been given for both groups except for the treatment. Say instructions given should be similar. The visits also should be similar. The frequency of visits should be similar. The investigations carried out also should be similar. And then if there shouldn't be a difference between the two groups during the follow-up. And then if you did not do that, it affects the balance achieved at the randomization. Dropouts invariable, because you generally say in the concept that if you want to get dropout, you can get dropout. So we're not going to forcefully keep them. So the dropout is invariable thing. But then dropout really affect what are called the outcome of the study. So that you have to be a little careful about it. Now, dropouts are actually people who are getting dropout and not voluntary removal, because that should not happen really. And missing data can be adjusted. There are various ways that you can adjust missing data, and too many dropouts can compromise the validity of the data. Now we have a small rule that the dropout should be less than 10%. It's a rule which we picked up from the AI or something like that. There's no reference for that one, but generally we believe that it has to be less than 10%. And also we say it should be roughly equal in both groups. There can be a situation where 2% get dropout in one arm and 10% getting dropout in other arm. It should not happen. That should be roughly equal. And also it should be symmetrical in the sense that the reasons for dropout need to be equal. For example, let's say people change in the residence, and that also should be equal. Like, people not contactable need to be equal. So otherwise there's a little bit of problem. But if it is more than 10%, we get involved what I call sensitivity analysis. And the sensitivity analysis we do just to make sure that the results are still can be believed. Now, there are various ways of doing sensitive analysis, and this is one simple thing that we do. We create what is called worst scenario and the best scenario. The worst scenario, we say all dropouts had the clinical outcome. So we say all the dropouts had, let's say, acute myocardial infarction. We do recalculate the study. And then the best scenario is that none of those people who got dropout had an acute myocardial infarction, did not develop the clinical outcome. We recalculate and see whether the results would remain the same, roughly same. And if it's not, then of course there's a bit of problem. Then there are various ways of doing sensitivity analysis. It's much more complicated than that, but I'm not going to go to the details of those. The analysis, there are two main methods of analysis. The people, really speaking, the people who were randomized at the initially should be assessed at the end of the study. So all, let's say, 120 people who were randomized at the beginning, and you must assess all 120 people, including dropouts, really. So that is what's called intention to treat. So intention to treat takes, analyzes all the patients who are randomized at the baseline. You work out what are called the missing data. There are various ways of doing that, and then you still keep them in the analysis. But then the other form of analysis, what's called per protocol, that is you analyzing only people who finish the study. And it is not such a good method because the per protocol and does not give us such a credible information with the analysis, and intention treat is much better really. Now, outcome measures, there's a surrogate of clinical endpoints. There are two things that we look at. Let's say a study which is looking at acute coronary syndrome. Acute coronary syndrome becomes what's called clinical end results. The lipid changes, the blood pressure changes, and others will become what are called surrogates. So there are what's called surrogate endpoints and the clinical endpoints. For example, in osteoporosis, fractures become the clinical end results, the primary outcome, and the surrogate or secondary outcomes are the bone mineral density changes and maybe the biomarkers changes. Those are what are called surrogate. And they should be defined without any ambiguity. And also problem is whether you have what are called composite clinical outcomes. Now, this is rapidly violated, actually increasingly violated in clinical trials. When you have composite, there's no problem with having composite clinical endpoints, but then there should be commonality. There should be commonality. For example, you can combine acute coronary syndrome with, let's say, DVT, what's called gangrene of a foot, or maybe stroke. They can be put together because they are major vascular changes. But then you should not have a percentage change of cholesterol and acute coronary syndrome as a what is called composite, because they are complete different concepts really. Now, this particular study, which again published in 2023, you can see that when you come to cardiovascular deaths, which was a primary endpoint, there's no significant difference between the two groups. And we see to the heart failure, there's no significant difference between the two groups. Hospitalization due to heart failure, not really. Then what happened is that the authors put all together, and then they found that it is statistically significant difference between the two groups, which is not really, which shouldn't be done, because the cardiovascular death cannot be combined with what is called the hospitalization for heart failure, because these are complete two different concepts really. So, but then they put together, and then they found a statistically significant difference between the groups, and they managed to publish that in one of the high-end journal. So that is something that you have to be careful. There's a rule about composite endpoints, how to calculate this thing. The results should be expressed in simple manner that a clinician should be able to understand. If it is something which is very complicated, and then use statistical tests which have unpronounceable name, like kind of Russian, Ukrainian kind of name, and that you can't pronounce, then you need to be a little suspicious about it really. I always say that the results should be simple and that the clinician should be able to understand it. Now, what do we have? We have what are called numerical data, like let's say blood pressure, lipids, sugar, all the what are called numerical data. So there should be, let's say, you can have a change in mean systolic blood pressure in the treatment group. So you can say a 20 millimeter reduction in the mean systolic blood pressure in the treatment group, and with this all within the group difference. So within the group, blood pressure difference so much, and there can be a p-value. This is a significant difference from the baseline to the end of the study. There can be a change of the mean systolic blood pressure in the placebo group, let's say 9 millimeter, and that is what's called again within group difference. Now, those two are what are called within group difference. Within the same group, there's a difference. But then they compare between the two groups, and you say change in systolic blood pressure, mean systolic blood pressure in the treatment group versus placebo group, and that is only 10 millimeters, and that is what's called between group difference. So, between group difference, then there's another p-value. So, there should be a p-value for the first difference in the treatment group, a difference in the what's called the placebo group, and then the difference between the two groups, what's called between group difference. Now, when you got dichotomous data, like event or no event, fracture, no fracture, acute coronary syndrome, no acute coronary syndrome kind of thing, and then those are what's called clinical endpoints. You can say risk of stroke in the drug A group, let's say 10%, and the risk of strokes in the placebo group, maybe 25%. And then what's called, you can have a relative risk, one divided by the other, of stroke associated with the drug A, and that is 0.4. Now, if you want to work out what is called relative risk reduction, RRR, 1 minus relative risk, that's 0.6, and that is where we say 60% reduction of the risk of a stroke, and that is why that 60% comes, and that is 0.6. Now, also you can calculate what is called absolute risk reduction, that is 25% minus 10%, that will be 15%. Now, why absolute risk reduction is so important? Because we can calculate what's called NNT, number needed to treat, That is 100 divided by the absolute risk reduction, and that becomes 7. So 7 people should be treated under that particular condition in order to avoid 1 stroke. Same thing can be done for the treatment harm. So you can calculate when you get particular side effects, and you can find out and how many people would be harmed. Treatment will harm how many people. Treating by, let's say, when you say 7 people, and you can say harm 1 person. The interpretation of the risk ratios. Risk ratios, odd ratios, and the hazard ratios, they are almost same, but there are differences between the fundamental differences between the 3. And but the interpretation is actually the same. So that's what I just want to say that. So what we need to do is we look at what is called 95% confidence interval. How it is interpreted is that if the relative risk is 1, we know same event rates in both groups. So let's say I had a 10% in the pre-treatment group, a 10% in the placebo group, a 10 divided by 10 would be 1, so that the RR would be 1. So if the confidence interval, 95% confidence interval include 1 or crosses 1, that means results are not significant. So that's a simple theory. So let's say, for an example, there's a relative risk of 0.65, and the confidence intervals are 0.48 to 0.85. Good, because they both are away from 1, and then it's a significant results. But let's say you have RR value of 0.65, but then the confidence intervals crosses 1. And however much the authors say, that can't be significant. But what is more dangerous is look at the third scenario, where the RR interval is 0.65, and they manage to stop at 0.99, the confidence interval, and then squeezes p-value of 0.045, very marginal. And they can go on boasting about it, saying that, but again, that it is very, very marginal, because it just escaped 1. And then they got a p-value all right, but that can depend on many factors like a sample size and all, and then that can be a little suspicious. Subgroup analysis, another problem that we had to be mindful, because sometimes they say this particular drug is effective. Let's say French-speaking people living in Netherlands and all that type of subgroup analysis, like not for everybody. But if you have got if you are French-speaking woman wearing short skirts and all that, this particular drug can be effective, because they go to subgroup analysis that much really. Subgroup analysis should be specified in the proposal. We call priori. So that when this proposal is submitted, they should say, we will go with the subgroup analysis, because we find this particular drug may be differently effective between 2 genders, maybe smokers amongst non-smokers, so that they have to identify at the beginning, but not after data collection, and certainly not after primary analysis where they can't find a significant difference. But it's called post hoc analysis, which should be discouraged. And also that the group should be biologically or clinically meaningful, like genders, or maybe duration of the disease, or maybe comorbidity. Also not too many, because it violates the statistical principles. The running period is, there are certain studies which describe what is called running period. It's not a bad thing. You keep that patients before randomization, generally use that period to prime your patients. For example, if they have high blood sugar, you normalize their blood sugars, and you correct their vitamin Ds and all. So you can do all that during the running period. But you should not try to expel patients who are having poor compliance. Let's say you give vitamin D to correct this thing, people don't take vitamin D, and don't get rid of that patient, don't eliminate that patient, because that people should not be eliminated during the running period. And then you will have problems in the final results. I'll go to the meta-analysis very quickly. Why we need meta-analysis? Because it's very well known, because individual studies are not conclusive, should be not conclusive, not inconclusive, or not, they are inconsistent. So individual studies do not give a consistent results, they are not conclusive, so you have to increase sample size and the event rate, and then increase the power of the study. Now, what are the limitations? Limitations are the outcome depends on the quality of the studies incorporated. This is where the Jadad score, the quality assurance become important, because we have this theory, what is called garbage in, garbage out. So if you put a poor quality studies into the meta-analysis, what you get out as is a poor quality outcome. So it's called garbage in, garbage out theory. So remember that the studies should be quality studies, which are judged by generally by a scoring. And also there are what are called inconsistencies in the subjects, and maybe interventions and controls, outcomes and analysis. They can differ from study to study. As a result of that, we have got what is this concept called heterogeneity between studies. Which studies are generally, they are different from one another with regards to those factors, and then the heterogeneity. Now, you must check whether what database, electronic database have been used, and it's mandatory use PubMed plus another at least 2, and the reference list of the relevant articles have been sort of cross-checked. Sufficient description of the search strategy, have they used the mesh as well as free text in PubMed, and what are the mesh or free text terms that were used, and their appropriateness, where they are okay. Have they used a drug as a group or individual drugs? For example, let's say you might search for bisphosphonate. And then also somebody might say, no, that's not good enough, because some particles might not publish as bisphosphonate, might say it's an individual drug. So you have to search whether they have searched on the group of drugs or individual drugs. Whether Boolean operator have been used effectively and correctly. And the limitations, people have sort of, limited that to English language. That's a general thing. And unpublished data, how they handle unpublished data. And you are supposed to write to the drug manufacturers, and ask them, not manufacturers actually, the companies, and ask them whether they have got what are called unpublished data, the clinical trials they have run, but they are not published. Now, this particular study indicate what databases have been used, and how the Boolean terms have been sort of, what Boolean terms have been, how they combine using Boolean terms. So that's a little description of the terms. Generally, 2 authors independently extract the evidence, extract the information, and some report the agreement between the 2 assessors. For example, let's say we had about 30 articles, and then assessor A goes and select them to what are called included, excluded, not sure, like 3 groups. And then the assessor B, again blinded to the outcome of the assessor A, again categorized, saying that the studies which are coming in, going out, and which are uncertain like. And then we assess the agreement between the 2 using what are called kappa statistics, and there should be a good agreement between the 2. Okay? And also then they have to sit down and then get the uncertainties, they have resolved uncertainties and how they were resolved, and also important. And what information were extracted, and also how they accounted for missing values. For example, let's say you collect the mean value and the standard deviation, and then let's say all studies have not given standard deviation, maybe only what I call the bars shown in this thing on the figure, and then how how they handle that situation. And this is how they say data extraction. 2 investigators called TS and LD, blind to the source, publication date, authors and affiliations, use a standardized extraction form. And all papers were then evaluated against the 11-item scoring system. What's called PDRO is something like a JEDAD, and there's another system that they use to score the quality of the studies. Checklist: possibility of missing relevant information, the sensitivity of the search method, possibility of eliminating the relevant studies, what's called selection criteria, have they extract the relevant information. Now the results section, the number of studies and the details need to be shown. Flowchart, usually you have flowchart. That is the flowchart to indicate the selection process. Say the first search gave so many, and say that the non-English publications and these were eliminated, and then 5 of those, and then generally say how the sort of came to final number. So that generally need to be included. The main results, it comes, this is what should be given, and then you all familiar with what is called the forest plot, and these are what are called components of the forest plot. Remember that there should be the first column should give the author and the year of publication. So that's the first column in the forest plot. Sorry, in this particular figure. The second column should give what are called the event rates in the 2 arms. Now this one has got displaced a little bit here and there, but this is a treatment arm, that the event rate, and the control arm, the event rate in this particular study. So that should be given, and the summary at the bottom. Okay? And this is what's called forest plot. I'll come to that later. Forest plot this area. And then the last column gives what are called risk ratios of individual studies and their confidence intervals. So these are the key components in the forest plot. And then in the forest plot, again, have a look at the details here. This box is what is called the estimate, maybe RR value, and then whiskers are what are called confidence intervals. You can see that confidence interval, and so individual studies and displaying the estimate and the confidence intervals. And that is called the line of null hypothesis. That is 1, that is the line where everything becomes non-significant. So you can see individual studies showing the estimate and the confidence intervals. The diamond is a summary statistics. You can see the summary statistics when finally it is done, it comes as a diamond. What these boxes, size of the boxes means the contribution made to the final results by individual studies. You can see that in this particular study, these 3 are the major contributors for this one. That's because they are more kind of, had a higher study sample and then had more credible information. As a result of that, those 3 contributed more to the final outcome. And again, something same here. You can see that what is called the forest plot. And then here what we're trying to highlight, what is called heterogeneity between studies that need to be examined. There are 2 ways of doing that. One is called eyeballing, and that is what the clinician should do. See whether you can draw a line which can cut through all the confidence intervals, which that line can cut through confidence intervals. It's called eyeballing method. Okay. Another one is what is called I-square, and then it goes from 0 to 100. You can see that this particular study and give I-square statistics, which is 38%, which is not too bad really. That's what's called heterogeneity between the studies. Finally, meta-analysis, what's called funnel plot. The funnel plot is given in certain publication, and funnel plot should be like this. This is what are called publication bias. And these are the studies which are a small sample size, which are having a wider confidence intervals, and these are what are called the good studies with a large sample, with a narrower confidence intervals at the apex. So you can see this particular study, and they are missing certain publications. Publication in this area is missing, so there seems to be a problem with the publications in that area, seems to have missed. Finally, I go to the lab investigations, and the diagnostic test. There are 2 things that you look at, what is called the performance of specific test for a given condition. So you are given condition something SLE, and how this particular test would perform and for this given condition. And the second one is determining a suitable cutoff value for the diagnostic test. And almost we check on what is called index test, that is test to be tested, and the reference standard. We have got what's called reference standard. We used to call it gold standard those days, but now don't we call it gold standard? And because there are no gold standard tests in reality. None of these ones are gold standard, like, ideal husband, ideal wife kind of thing, they are not existent. The patient must be representative so that the consider spectrum of the disease, whether they include the people with a milder disease and people with what I call severe disease. And all people must undergo both tests without a time gap. That's the important thing. So both people, they should face both tests. And also there should be a time gap between the 2 tests. And nurses should be blind to the results of the other. For example, let's say when people undergo, let's say, test 1, and then the people who are doing the test 2 should not know the outcome of the test 1. So they should be blinded. Now, there are various sources of blind that was published in 2003, what's called spectrum bias, not including the entire spectrum of diseases that tend to overestimate. Bias due to inappropriate reference test, so that you are using a reference test which is not appropriate. And also what's called review bias, when the assessors are not blinded, so they knew the outcome of the previous investigation. So they were biased towards this thing. The partial verification when not performing both tests on all patients may be expensive reference test, and they only did it for the patients who become test positive in the previous one. A differential verification bias when alternative reference tests are performed on index test negative cases. Analytical bias, wrong statistics. Indexing bias, positive studies are more visible. and then what I call these language bias, non-English publications. So these are the various sources of bias. The test performance is analyzed in the way of sensitivity and specificity, we all know. And let's say these are referenced as positive cases, referenced as negative cases here, and they're always looking from above. And these are the index test positive cases, index test negative cases. So always we put them on side, on the row. So that's a rule. So if you say these are the A, B, C, D, and you can measure true positive, true negative, you can do that as well. So sensitivity is the rate of index test positivity among those with the disease. So those with the disease would be A and C, and then only people A became positive, so A divided by A plus C. Specificity, the rate of index test negativity among those without the disease, so there is a B and D, those without the disease, and then D divided by B and D. So sensitivity questions, what is the probability of being a test positive if my patient has the disease? And the specificity says, what is the probability of being test negative if my patient does not have the disease? Now, although sensitivity and the specificity is very, very popular among the clinicians, and then this is a bit of a rough, difficult thing to handle. Say, what is the probability of being test positive if my patient has the disease? How do you know your patient has the disease? That's not what you need actually. So you don't know whether the patient has the disease. Clinician should be asking, what is the probability that my patient with a positive test has the disease? Let's say you run a test and found that positive, and then you should ask, what is the probability of him having the disease? Now he's test positive. Let's say, what's the probability of my patient not having a disease, and now it is test negative? So you have only the patient, a test results, and you should be questioning, has he got the disease or he hasn't got the disease? But the sensitivity specificity asked in different manner, which will be difficult for the clinician to handle. So these are in what is called positive predictive value and the negative predictive values that we should be more using. They are actually on the other way. Let's say the test having the disease in the test positive patient, A divided by A plus B, and then D by C. So it's the other way around really. Now, we come to the final concept, what is called the ROC analysis, the receiver operating characteristic curve, and which is used in biomedical research. And this actually came with, there's a story, this came with the radar system. And radar operators, in fact, introduced this system. And then there's what's called area under curve. So this is the line. Again, 50% divided into 50%, and this is what's called area under curve. Whole thing is AUA. So if it is 50%, and then we know that is not significant. It has to be more than 50% for it to be significant. It should be moved towards this way, right? So when the ROC analysis is done, you must say what is the area under curve. It has to be more than 50%. If it is about, let's say, 100%, much better, and then there will be a level of significance. If it's 80%, 90%, there will be a level of significance. And then the other point is how the cut point means that is the threshold was determined. And there are various ways determining threshold. For example, let's say you are running a TSH, new assay, to determine, find people with hypothyroidism and people with no hypothyroidism. And then how do you take cutoff value? Again, you do a ROC analysis and see whether it has a good area under curve. And having seen a good area under curve, and now you see whether you can get a cut point. Usually cut point come from here. There are various methods of doing that, and then, we will leave it. And then once you have decided on the cut point, and then you have to examine and see what is the sensitivity and the specificity of that particular cut point. And because all the cut points do not give us same specificity and sensitivity. Some are more specific but not sensitive. Some are more sensitive than more specific. So that the clinician needs to sort of decide on that. So that is what is called the determining of the ROC curve and the cut points. So summary, and the clinician need to be updated on recent developments in the medical field, and it's very, very difficult for someone to practice, and unless it is done, because I think probably nearly about 90% what I have learned in the medical faculty are incorrect now. and so that even what I learn as a registrar and is not relevant now, so they're all gone. So unless you know the new information which is coming, and also keep updated with the information, and then you cannot do a good job as a clinician. And then how we handle this information overload, because information become really, many may come from all over, and then in many directions, and then how you handle that information, and also particularly how you filter out what is called fake studies, and also look into what is called research misconduct, and the manipulation of the results is again something the clinician need to know. So only way you can do is actually you appraise your critical appraisal skills, and you update, and you acquire those skills, and it's a continuous process because newer and newer research methods have been introduced. And for example, let's say now the placebo-controlled clinical trials are becoming less and less prevalent, and then non-inferiority or equivalence studies are coming, because it's unethical for someone to treat people with a placebo when there are what are called definite treatment options are there. So you do what are called the non-inferiority or equivalence trial, which are interpreted completely in different manner. I not go into the details of that. So it should be a continuous process, and just 1 hour lecture cannot cover all that. And also there should be commitment in the side of the clinician, so that you stay committed for this, and then you update on these particular skills. So thank you.
Thank you, Prof Lekamwasam, for that interesting lecture. I think we can take about 2 or 3 questions from the audience. While they come up with the questions, can I ask a question? You
Sure,
said
sir.
post-hoc analyses are not much in use, but we still see a lot of post-hoc analysis being done. Do you think we have to completely get away with it, or is there some clinical use?
Yeah, there are post-hoc analysis means very particularly with regard to subgroup analysis you are referring to. Yeah, there are various forms of post-hoc, but then we are mainly focusing on subgroup. Yeah, subgroup analysis is very common in clinical trials, because particularly when the main analysis, when the whole group put together, and then you run the analysis and you find that there's no statistical significant difference between the two groups, and then that's the time that they go on analyzing, and then they look at, let's say, a male versus female, and then the Asian versus non-Asians, and like that, keep on doing that, and then until you kind of find a statistical significance, so that they can write something about, or at least make a little ha-ho about it. Generally, those are discouraged, and unless they are clinically meaningful, the clinician should say, hang on, it is clinically meaningful, because this particular patient should be seen in different manner. And let's say patient's diabetes, and then you are running it again for the people who are having a renal disease is not a bad thing, because lots of people with the diabetes have got renal disease. So a subgroup analysis among the people who have got renal disease and see whether the treatment is still effective is not a bad idea. But again, it's many subgroup analysis and all that, it should not happen really. It compromises. Qualifications, sir. Thank you.
Where does it come in this critical appraisal?
The level of evidence may also come in what is called the developing guidelines. Yeah, where the guidelines, we have got level A evidence, level B, and again divided into various forms, and then generally they had to give a little grid saying that these are the kind of, what are called the qualifiers for different grades, that they say, let's say grade 1 evidence come from meta-analysis or systematic review or a large randomized controlled trial. So that is generally used when you are developing guidelines. So going up to the randomized clinical trial meta-analysis, going up to the expert opinion at the bottom, So that. Yes, Shan.
About the point that you were talking about. Hope I haven't put you on a suit.
Yes. One way is to find out, if I can go to my slides again, I don't know. Is it possible for me to go? Yeah. And go to the right-hand corner. You know, the curve become closer to yeah, here. Now, it is actually, the test has good performance as it gets closer to this particular point here, right? So then what happens is you draw a diagonal, this in line here, a diagonal line
Sorry, sir,
between this and that.
Sorry, sir, the cursor doesn't appear on it. If you can just show it with the
Is it? This cursor is not here?
pointer doesn't.
Oh, this is a pointer. All right, okay. Okay, thank you. All right, okay. So it become more and more sort of, trying to reach this particular corner and become the test has a better performance. So, right, rather than sort of, say somewhere near this particular line. And then when you get that, you draw a diagonal line here, diagonal line, a diagonal to this particular line, and then see where it cuts here on the curve, right? And then with that you see what is the sensitivity here and what is the 1 minus specificity. So this is sensitivity here and this is 1 minus specificity. Okay, so that is one way to do that. And also there's another scoring system where you put the sensitivity plus specificity and trying to reach what is called the highest value in that. So sensitivity and specificity put together, and then you're trying to get the highest value. So then you look at the series of values and then see where you can get the highest value when you combine sensitivity and specificity. That's another method of doing that, right? So generally what we do is do about at least 2 methods, and when you go for a publication saying that we check with both methods.
Thank you. So in the interest of time, we will close this session, and I cordially invite Prof Lekamwasam to come forward to accept the certificate.